Hello, everyone. Welcome back to Luncheon with the Experts, a Carcinoid Cancer Foundation program brought to you by Ipsen Biopharmaceuticals. My name is Rain Bennett. I am your host this week and every week, and I'm a filmmaker and a writer that's been working with CCF for 10 years, actually a little bit more than 10 years, I think 11 and now going on 12. So a long, long time, over a decade, we'll put it that way. And creating video content, all kinds of video content in that span of time, live video series like the one you're going to watch today, kind of Q&A sessions, topic-based videos, patient-centric stories, documentaries, conference of videos, all kinds of videos, which are free and available to you to use. But they all had the same mission in mind, and that is to spread awareness and education about neuroendocrine tumors. That is what we are here to do. Now, the value of the show that you're going to watch today, if you are new to this journey, if you are new to the show, if you just found us recently, I want to say welcome. And the value you're going to receive today is twofold as I see it. One, the information you're going to get from our guest presenter, who is very good and been here multiple times. And two, the shared experiences, shared stories, and support that you're going to get from the community. If you look in the comment section, you see people already chiming in, saying hello, telling us where they're from. Do the same. Embrace the community. Reach out. Introduce yourself. I promise you they will embrace you back. This is one of the most supportive communities I have ever seen, with medical experts, with support group leaders, caregivers, patients. Everybody works together to help each other through this. And so I encourage you to lean on that. It is for you. Before we get started, we always want to thank our sponsors, Ipsen Biopharmaceuticals, because without their support, we couldn't do Luncheon with the Experts. And we have this disclaimer from them, and that is that the opinions expressed by the guest presenters today, as well as the questions asked by you all, the audience at home, haven't been created or suggested ahead of time by the sponsors of Luncheon with the Experts. And CCF doesn't endorse or promote any of the views, opinions, or information provided in this presentation. So, audience members should not rely solely on the opinions or information expressed by our guest today, and should seek guidance and direction from their own medical advisors regarding any choices they make about their health or treatments. Okay, that last line is really the takeaway. We don't know your specific case. So take this general advice that we give you, take these answers to your question back to your home team, which does, and make the best plan and path forward for you, because each case, one thing I've learned, I'm certainly not a medical expert, but each case of this disease is unique, and therefore each plan and path forward is as well. Today, I'm very excited to welcome back to the show for at least a third time, who was here not that long ago, just a couple of months ago. So I will say, back by popular demand, and I mean that, Dr. Jaydira Del Rivero. How are you, Dr. Del Rivero?
I'm good, Ray. How you doing today?
I am doing great. Welcome back to the show. We appreciate you being here. Now, for those that may not have seen any of your earlier episodes, tell us a little bit about what you do, where you work, and the role that you fill in this net community that we've already talked about.
Great. Thank you so much, Ray. Well, first, I want to thank everyone for giving me the opportunity to be here with you all today. And it's my pleasure of being one of the inviting me or give me the opportunity to answer any questions that you may have, and please answer any questions. I'll be happy to answer the best of my ability as well. I am a medical oncologist. Well, a little bit of my background. Before I decided to do a second fellowship, I did an endocrine fellowship. And when I was seeing patients with endocrine cancers at that time as an endocrinologist, I decided to go back and do more training and become a medical oncologist. And to me, it's given me kind of like a whole perspective of how these endocrine tumors can be managed, especially when they produce hormones as well. And now here, I'm a main role here at the National Cancer Institute. This is a medical oncologist. I am currently the principal investigator of a natural history study for neuroendocrine tumors. That natural history study allows me to follow patients long-term and to also understand about the biology of these neuroendocrine tumors, do genetic testings, molecular testing, the imaging testing, and so forth. I'm also the principal investigator of a treatment study together with Dr. Perez. I believe Dr. Perez will be here next week.
That's right.
Yes, and fortunate to work with her, and we have a treatment study for another type of neuroendocrine tumors, a more rare type of neuroendocrine tumors called pheochromocytomas and paragangliomas too. We also here at the NIH, because of our interest in endocrine cancers, and we also have another study with Dr. Franklin, who is a nuclear medicine physician here, of Lutathera in combination with olaparib, and I'm happy to discuss more in detail about that. I think that we are a multidisciplinary team here where I am, so I'm very fortunate to work with surgeons and nuclear medicines and interventional radiologies and radiologists. We are a multidisciplinary team, and we do have an interest in neuroendocrine tumors, understand more about that, and also understand about the biology, and hopefully develop better therapies for neuroendocrine cancers.
Awesome. I love to hear it. So folks, I promise you, this is going to be a great episode, especially because of Dr. Del Rivero's specialties, wide ranging, but you're going to, I know a lot of these topics we always have questions about, specifically about the studies going on. There's a lot of interest, a lot of activity going on right now. In fact, Susan in the comments says, hi, I'm at the NIH this week for the familial study. Hey, Susan, that's great to hear. And also, folks, you may remember we've been doing a patient-centric documentary series right now. We just released our second one from Mel Phillips, which was out a few weeks ago at the end of September. So check out that if you haven't seen it. The month before that, we had Eileen Bildman. And I just got back from filming one, which will be out in November. But Mel Phillips, our episode 2, is also in that study. So we talk about that a little bit and telling his story. But yeah, I'm really excited about that series. And so we will be bringing our next one to you the last week of October. So stay tuned for that. We got people all over. Lisa says, hello, love Dr. Jaydira Del Rivero. Hello, Lisa, our friend from Los Angeles. So folks, a little bit of housekeeping. Hi from the PheoPara Alliance. We love our friends over there. A little bit of housekeeping before we officially get started. Go ahead and start sending in your questions. If you're new to the show, a couple of tips that will help get your question answered. Listen, our goal is always to get to as many of them as possible. Inevitably, we don't get there because we get so many. It's kind of a good problem because it allows us, it's the fuel that allows the show to keep going on week after week. But we want to try to get to as many of them as possible. So one way you can formulate your questions in a way that helps me get them answered is to ask them very simple and generic terms. Again, Dr. Del Rivero doesn't know your specific case. Most likely she could be your doctor, but you ask in generic terms. If we get really dense and case specific, it's really hard to do that in this format, right? What we can do is try to get you to somebody who can help you. But today, ask your questions in generic form. You can ask as many as you want to, but if you ask them in little short generic questions, it's easier for us to get to them versus 2 or 3 paragraphs when we got a lot of people asking them. But if you see a question that's in the sidebar in the comment section that you also have, or you're interested in the answer to, just under that question, you can like it, love it. Any of the emotions that Facebook allows you to use, they all work the same way for me, and that is to effectively upvote that question. So as I'm browsing through them, if I see 10 people have the same question, I'm definitely going to make sure I get that one across to Dr. Del Rivero. And finally, one little tip, I mentioned this as much as I can. Sometimes I forget, but we have people all over the world tuning in today and every week. And some great feedback that I've gotten from our foreign friends. Sometimes having the subtitles on helps. So if you don't know about that feature, the bottom right-hand corner of your Facebook page, when you're watching this call, there's a few icons. It controls your volume. It lets you go full screen. And there's one that says CC. And if you hit that button, that's for closed captions or subtitles. It'll pull up the option live captions. And if you hit that, you'll be able to have subtitles going on. And this isn't just this is also if you're listening in a place where you don't want the audio super loud, you can read along at the same time. So that's something that people have been really appreciating. It's a nice function that that Facebook gives us. It's AI, so it's not 100% accurate, but it's pretty close. So I think it'll be very helpful. So we'll try to get to all your questions. If we don't, please feel free to follow up the Carcinoid Cancer Foundation. You can visit their website, which is right behind me at carcinoid.org, or just send them a message here on the Facebook page. So go ahead and start sending in your questions. We're going to start taking them now. We've already got a lot coming in, Dr. Del Rivero, like I thought we would. I have a question. I want to talk about that. I'm interested in learning a little bit more. If you could share about that treatment study with olaparib and Lutathera. What exactly are we looking at? What are we hoping for? I know combination treatment is kind of, there's a lot of activity going around that concept right now. So tell me a little bit more.
Yes, thank you, Rain. Of course, yes. We're excited about this study, and let me explain to you exactly what we're doing with this
Please.
study. So we know Lutathera is approved already for the treatment of pancreas and GI neuroendocrine tumors. It's not necessarily approved for lung neuroendocrine tumors, but there is a study ongoing that is led by Dr. Hope from UCSF, who is trying to understand also whether, given Lutathera to lung neuroendocrine tumors, could they also see the same activity as well as we see it for pancreas and small bowel neuroendocrine tumors. Now, we know that Lutathera work. We know that the majority of patients stabilize the tumor, but sometimes the question is, could we make treatment more effective? And I think that's one of the questions that we have as well in the neuroendocrine tumor field, like what is the sequence of treatment, how we can make treatment more effective, and what will be our first line followed by the second line treatment. So I think this is kind of like some of the questions that we have. And in terms of Lutathera, we want to combine with olaparib, because the question is whether the two together, could that be more effective? Could that shrink the tumors? So let me explain to you a little bit about the rationale about Lutathera in combination with olaparib. So Lutathera is a type of radiation treatment, and when is given into our bodies, that cause breaks into the DNA and the DNA of the tumor. So our body, what is trying to do is repair that DNA. So it senses something and it's going to try to repair. Olaparib is one of those drugs that inhibit DNA repair. Olaparib has been approved for the treatment of breast cancer, ovarian cancer, even now in the studies as well for pancreatic adenocarcinoma, as well as prostate cancer as well, because that inhibits one of those DNA repair genes as well. And by inhibit that repair, the question that we would like to answer is whether we can make Lutathera more effective. The same rationale is in other studies also led by Dr. Shahan. Dr. Shahan has the study of Lutathera in combination with triapine and Lutathera in combination with another drug called peposertib. And the rationale is the same. All of those drugs, we call it DNA repair inhibitors. So the idea is to inhibit the repair of the cells so we can make Lutathera more effective. And that's some of the questions that we want to answer by doing this study.
Awesome. That's very exciting. And we actually had on Dr. Robert Ramirez last week talking specifically about lung nets. And I know that that's an area where people are really interested because it hasn't technically been approved, but I know it has been used in some cases. So that's very exciting. Well, kind of in that vein, Donald has a great question coming in here that I know is often asked. So Donald says there's been a lot of discussion on the sequencing of treatments, as I know that there is. And the question is there any guidance on duration of time between treatments? And Donald also says, thank you for all that you do.
Oh, great. Thank you so much for that question. I appreciate it. And I mean, that's a great question. I mean, that's one of the questions that exactly the NET community would like to answer. What is the sequence of treatments? I have to say that I was just recently at the ESMO meeting, that's the European Medical Oncology Society, and they presented some studies for neuroendocrine tumors. And one of the studies actually wanted to answer that question. So they basically, what they did on that study is in patients with pancreas neuroendocrine tumors, starting chemotherapy followed by everolimus as a second line. And the same, there is two arms of the study, two cohort of patients, one getting chemotherapy first and followed by everolimus if there is any growth of the tumors, and the other cohort of patients is everolimus followed by chemotherapy. And that's exactly one of the questions that we want to answer. This is the first sequencing studies that we can discuss about, but yes, that's a very good questions. We still don't know the sequencing. Usually when we have now drugs that we can treat neuroendocrine tumors with for pancreas neuroendocrine tumors as well as for small bowel neuroendocrine tumors. But yes, the question of sequences, that's something that we wanted to answer in the NET community. That said, whenever we choose an agent, we also need to take everything in consideration, right? How the patient well-being is, whether what is in terms of all of her, what we call the organ function, to what is the white blood cells, the red blood cells, how the kidney function. So sometimes that can also guide us as well, what treatments we need to start first in those situations. And as we know, and I think we have discussed this many times, the management of neuroendocrine tumors, we want to say that it requires a multidisciplinary team, because sometimes the management is very personalized patient to patient. So, and even surgery can be an option in a subset of patients, or liver-directed therapies with ablation embolization can also be an option. And that's the reason why we like to discuss, and that's a question in terms of sequencing. That's one of the reasons why we like to discuss with a multidisciplinary team to understand what is the tumor burden, meaning how many tumors in the bodies are found, whether the tumor expresses somatostatin receptor or not, whether it's only in the liver and not in other parts, whether it's rapidly growing versus not, because sometimes that can also help us determine what will be our first line of treatment. And that's the reason why I always emphasize that discussing this patient with a multidisciplinary team help us also understand what treatments we can offer to our patients.
Absolutely. I just want to say hello back to our friends at the Healing Nets Foundation in Nashville. Hey, Tracy. Julie says, Dr. Del Rivero, is the NIH still doing televisits for second opinions?
Yes, we do. We actually can do second opinions as well. And I just wanted to, if I can make a comment, Rain, as
please,
well.
Of course.
Earlier, somebody was mentioning about the natural history of familial too. So I just wanted to mention as well that here at the NIH, we have another investigator. His name is Steve Want, who has a natural history study of familial carcinoid. So what we know is that most of the neuroendocrine tumors, they are sporadic. So meaning we don't know what is the cause. Approximately 10% of neuroendocrine tumors may be familial, and I'm happy to talk about that. But we also have this familial carcinoid as well. And Dr. Juan is basically following these patients. So maybe what Susan earlier was mentioning is maybe that study of familial carcinoid, which is something that is not very common, but is something that we have seen in patients with some patients with small bowel neuroendocrine tumors. And when I say familial, I wanted to mention that most of the pancreas neuroendocrine tumors are the ones that are familial, but not necessarily the small bowel. The fact that we have this kind of like new let's say terminology with familial carcinoid is something that here at the NIH we're studying as well, and Dr. Juan is studying those patients. The study that I have for the natural history study, I include everyone, not as familial syndromes, but also sporadics as well. And we can definitely continue with televisits as well, and those situations.
Got it. Thank you. And Beth, who asked about Susan, who commented on the familial study, I tagged her in a comment to you from my personal page, so hopefully you saw that. Folks, this is Luncheon with the Experts, the Carcinoid Cancer Foundation program. If you joined us very recently or a little bit late, we are here with Dr. Del Rivero from the NIH today. And I have a special announcement. We talked a little bit about one of our patients that we featured a story on. That is also doing one of the trials at the NIH. So this is some big news. We haven't done this before, but we are extending the series. And I wanted to reach out to you all because I thought, what a better place. We tell these great stories of hope from patients all around the world, all around the country. I'm going to put my name here in the comment section, and I want to ask you all, if you know of any NET patients that have great stories to tell, let us know. Send me a message. I'm going to put my name right down here. Here is where you can reach Rain. There you go. Send me a message if you have any great stories of hope from NET patients. We'd love to consider telling them. There's no guarantee, but I'd love to have a chat with you about it and hear the stories. We've found some really, really cool ones lately that we're excited to share. But this community is so strong. We all know so many people. I figured that you all would probably know some great stories out there. And so if you know there's one that's deserving of a short documentary, let me know. Let's talk about it. So let's continue on with the questions. This is a question from Judy about research at the NIH. Does the NIH look first for research specimens or first for the best solution and health of the patients?
Mm-hmm. Yes, I can tell you by what I do in terms of my natural history study. So in terms of what I do with my natural history study, I like to see my patients. I like to review scans and records, and then I provide first an opinion of what, in terms of the course of disease, of what my recommendations will be. And that's usually how I start. I start kind of like what we call like a consult. We have a consult protocol that allows me to see patients as well. And I discuss after that my natural history study. If they have an interest in the natural history study, one of the things that we do, we can do things virtually, but also we can bring patients here, and then we collect blood for research purpose as well. We also collect tumors from prior surgeries. If surgery with some of these neuroendocrine tumors had surgery like 10 years ago, if we don't have tissue from those surgeries, then it's a possibility that we can do a biopsy just to obtain tissue. That way we can send the tumor for molecular testing as well. It's kind of like part of one of the questions that we want to answer as well. What is the number of mutations that we see in different neuroendocrine tumors? And also by follow these patients over time as well, we wanted to understand more about whether there is any other familial component associated with these neuroendocrine tumors as well. So it's kind of like different ways that I see patients. I think we like to follow patients and understand and give recommendations. That's something that any investigator here at the NIH do, especially at the cancer center. We like to definitely provide what is the best opinion based on the best practices. And then we also mention our natural history study as well, or other research studies if the patient will like to participate.
God, thank you. I want to say hello to Maria Gabriela from Brazil. I think this might be the first time I've seen your name. So if you are new to the show, welcome from Brazil. Appreciate you being here. So Robin says, I'm suffering from chronic carcinoid syndrome after the doctor said that the cancer is in remission, and I don't understand why. Is that possible? Why would that happen? What are your thoughts?
Well, first, we like to understand about a little bit more about what does that mean by, having symptoms of carcinoid syndrome. That's because it's mainly diarrhea related, maybe it's only flushing related. So first, we need to understand what is the symptoms related to the symptoms, right? Because we know that carcinoid syndrome is a series of symptoms. So it's not necessarily one symptom. It can be flushing, diarrhea, feeling anxious in certain patients. So I think we need to understand first what the symptoms are. And then based on the symptoms, it can help us guide us well whether we need to do any further testing. Sometimes what I have seen is that a patient that have neuroendocrine tumors and has undergone surgery, sometimes because they shorten the intestine, sometimes these patients may have diarrhea associated with for the surgery, not necessarily associated with any evidence of tumors. Sometimes there are even the lanreotide, just so that you know, lanreotide can also cause diarrhea too. I don't know if the patient is in lanreotide or not. That can also cause diarrhea. And I understand that you say, yes, but I'm getting lanreotide because that's controlling my symptoms related to carcinoid syndrome. But in those patients that they don't have those symptoms, because it's a medication that inhibits a lot of the hormones in the gut, that can also cause diarrhea. So we need to understand first where the symptoms comes from in order to provide guidance. I understand that sometimes, there are patients that have neuroendocrine tumors, and after that is resected and may have some symptoms without any evidence of tumors. We sometimes follow with Gallium dotted scans that we don't see any tumors. Sometimes the question is, could we have something really very small that is unable to see? It's hard to say, and that's a very puzzling question. And I'm so sorry that you're going through this, because I can understand how frustrated it can be that you have these symptoms and not knowing and not having any information on where it is coming from. But I do feel like, don't ignore your symptoms, continue following these symptoms, continue discussing with your physicians as well, making sure that we understand where this is coming from, because sometimes I can, like I say, guide us to also determine whether the treatment or whether the diagnostic tests we need to do. Absolutely. But if it's any help, I'm happy to help you and answer that question.
Hey, thanks, Robin. Yeah, a lot of different possibilities there, but if you have any context, clarification you want to add to that, please feel free to chime in and we'll try to get to the bottom of it. But thanks for your question. Thank you for being here. So this is a question for Dr. Del Rivero, or possibly anyone else in the comments. This is one of those areas where we can all support each other. Judy asked, can you recommend a neuroendocrine lung specialist in the Washington / Baltimore area? Not sure if you know anybody, Dr. Del Rivero. Sometimes Dr. Ramirez is lurking in the comments, so he could chime in, or anyone else. But any thoughts on that?
Yes, I mean, that's a good question, and you're correct. Sometimes when I hear lung neuroendocrine, the first person that comes to mind is Dr. Ramirez, of course, because that's one of his focus. I think in the past, any thoracic oncologists were the ones who were seeing more the lung neuroendocrine tumors. I think
Fair.
now any net expert is kind of like really wanted to understand more about the whole, all type of neuroendocrine tumors. I do see lung neuroendocrine tumors here at the NIH. I know that at Georgetown, Dr. Chul Kim also sees neuroendocrine tumors. Sometimes whenever I see a patient with lung neuroendocrine tumors, I sometimes talk to him so that way they can follow up as well with him at Georgetown. So yes, I mean, there's like, again, whenever I hear somebody's asking about lung endocrine tumors,
too.
Ramirez,
Me too. So can you repeat the Georgetown doctor's name again?
Chul Kim.
Okay. So Judy, hopefully that helps. But also we had Dr. Ramirez on last week, Dr. Robert Ramirez from Vanderbilt. And I think that he said that he's happy to take or at least talk with your doctors or take telehealth appointments. I believe he said that, but he could potentially help you too, or point you to the right person that could. Okay, next question from Jennifer. Is it common for neuroendocrine tumors / paragangliomas to be near arteries and veins or in lymph nodes and not in organs?
Yes. So let's first discuss about what is paraganglioma.
Please.
So paraganglioma, pheochromocytomas and paragangliomas are a rare type of neuroendocrine tumor. And why we call neuroendocrine tumors is because they have a specific markers that is look under the microscope that help us to determine whether it is a neuroendocrine tumor or not. So pheos and paras is a neuroendocrine tumors. Pheochromocytomas arise from the adrenal glands. So the adrenal glands are small glands that are on top of the kidney. Usually the way I describe my patient is if you cut the adrenal gland in half, you have the outer layer, which secretes other hormones, but then you have the inner layer that is responsible to produce adrenaline, the fight and flight response. So and whenever there is a tumor that arises from the adrenal gland, it's called a pheochromocytoma, and then we have a lot of the symptoms related to the fight and flight response. So what is paraganglioma? Paraganglioma is outside of the adrenal gland, and it can be anywhere from the neck all the way down from the pelvis, because we have like nerve change and all the way down from the neck to the pelvis. And paragangliomas can come from any of those areas, neck, anywhere in the chest, abdomen, pelvis. So some of these paragangliomas can be very close from the blood vessels, the main vessels in the body, like the aorta. And sometimes the most common paragangliomas in the abdomen is actually what we call an area that is kind of like the bifurcation of the aorta, meaning the main kind of like vessel in the body, and then divided into two areas to give the blood supply to the extremities. And sometimes right in the middle, we can find these paragangliomas as well. So these paragangliomas, yes, they can be very close from the blood vessels. And sometimes, they kind of like encase in some of the blood vessels as well. So it's very important whenever we have a patient with paraganglioma that we do the proper workup for diagnostics and as well for treatments as well.
Got it. Thank you. And thanks for your question, Jennifer. Next question from Stacy. How common is it for tumors to change hormone production? My husband has insulinomas, and now his tumors are secreting serotonin and calcitonin.
Okay. So that's a good question. And I have to say, that reminds me, there is a patient that I had that it was initially a lung neuroendocrine tumor, and that was producing serotonin, and then it was also producing as well of calcitonin. That was also associated with a syndrome. It's called it, and that was associated with actually NEM1. It was very uncommon to see that. So I have to say that I saw it once here, but it's very, very uncommon. So sometimes when we see a neuroendocrine tumors, we need to understand first where is the organ, where the primary could be, because based on where the primary could be, that can also, they may secrete certain organs, as if in the pancreas, they secrete certain organs, because the pancreas is a very juicy organs, and the pancreas is responsible for secreting insulin, for secreting somatostatin. So, and that's one of the things that whenever we see a pancreas neuroendocrine tumors and the patient has symptoms related to the neuroendocrine tumors, we need to understand whether it's functional or not. Functional meaning whether it's secreting hormones or not. So that's one of the things that we need to understand. So it seems, based on what I understand for the question, so first it was an insulinoma, so meaning it's a tumor in the pancreas that was producing insulin. The symptoms related to the insulinoma, it can lower the blood glucose as well, so it has symptoms of low blood glucose. But if we have another tumor outside of the pancreas, it could be the thyroid, for example, because the thyroid is the one that produces another type of neuroendocrine tumor that produces calcitonin. That's called medullary thyroid cancer. So when I see something like this, I need to understand whether there is a genetic background, whether this is a familial type of neuroendocrine tumors. Again, as I say earlier, most of the neuroendocrine tumors are sporadic. We don't know the cause. Approximately 10% can be familial. So sometimes it can come to me whether this could be a multiple endocrine neoplasia. There is four type of the MEN, or the multiple endocrine neoplasia. But yes, that's one of the things that I need to understand more in detail, whether if it's producing these different hormones, I need to do a genetic test, and I need to understand where the primary is coming from. Could they secrete different hormones? Is very, very rare, but I have seen it in a couple of patients too.
Got it. Thanks for your questions, Stacy. Next question from Perry. I have been diagnosed with adrenal cancer. I have completed 4 Lutathera treatments with success, as the cancer has not expanded. What alternative treatments could you or would you recommend? Okay.
So when I think about adrenal cancer, so I'm assuming it's adrenocortical carcinoma. So sometimes with adrenal cancer, like I say, the adrenal glands are little organs that are on top of the kidney. And as I mentioned earlier, we cut the organ in half. It has 2 layers, the outer layer, which we call the adrenal cortex, and the inner layer, which is adrenal medulla. The inner part of the adrenal gland, which is the medulla, is the one responsible if there is an excess of tumor that causes pheochromocytoma. In the outer part, that can, we call it the cortex, the tumor arising from that is called adrenocortical carcinoma. So just to let you know, we need to know the difference. Sometimes when you say adrenal cancer, I assume it's adrenocortical carcinoma, but it can also be a pheochromocytoma because it also rises from the adrenal gland. Now, pheochromocytomas are known to express somatostatin receptors. Approximately 95% patients with pheochromocytomas and paragangliomas can express that receptor, and we like actually that scan, dotted scan, in order to help us understand where the tumors are related to pheochromocytomas and paragangliomas. Now, in terms of adrenocortical carcinoma, very rarely they may express somatostatin receptor. I have to tell you, majority do not. But I know that there has been some case series, some cases report as well, where the adrenocortical cancer may express a somatostatin receptor. And whenever we see that, a tumor that expresses a somatostatin receptor, then can guide us to use, in these situations, Lutathera, because as we know, Lutathera, we need to have the receptors in the tumors in order to give Lutathera. Very uncommon, but if this is an adrenocortical cancer that receives Lutathera, things are stable, we can follow up. But I understand that most of these adrenocortical cancers are more of rapidly growing, but we have treatments to treat in those situations. We have chemotherapy, we have immunotherapy as well. We have another drug on the family of the tyrosine kinase. So tyrosine kinase are the type of drugs that blocks the blood vessel supply going into the tumor. So the ones that we have used for adrenocortical cancer is called cabozantinib. But as I say, there are different treatments that we can use for adrenocortical carcinoma. But as I say before, very, very important for all these endocrine cancers, neuroendocrine cancers, we need to understand first, where are the tumors in the body? What is the burden of tumors? What is, if it's only in one area versus the other, and whether it's rapidly growing or not. So that way it can guide us as well, what is the best treatment for those patients.
Got it. Thank you, folks. We are just a little bit over halfway done today, so still plenty of time. Great job. Great questions today. Keep them coming, and we're going to keep trying to answer them. Next question comes from Julie and several other people, it seems. How common is it for a small bowel net to go beyond the liver to the bone?
Yes. Thank you so much. And it's a good question. It's very uncommon to see neuroendocrine tumors going into the bone, but it can happen. We have seen, I have a cohort of patients, and we actually wanted to understand, just to let you know, those patients that have bone metastasis related to the neuroendocrine tumors, we're trying to divide those patients and understand whether there is any difference compared to the other patients that don't have bone metastasis. But yes, it's not very common to see bone metastasis. That said, a DOTA scan can also help me. We have two types of DOTA scan. We have a Gallium, 68 Gallium DOTA scan, and we have the 64 copper DOTA scan. I think nowadays we wanted to kind of like call it somatostatin receptor scans too, because now these type of receptors are used for other type of cancers as well. But yes, once this type of scan is very good to also determine how many bone metastases do we see in the body, because those bone metastases also have the receptors as well, and it can also help us understand about how many of them are in the body. Sometimes one thing that I want to comment here is sometimes these bone metastases can be in areas what we call weight-bearing areas, and that's something that we need to keep a good eye, because if that's causing pain and there is a risk of fracture, it's likely that we may recommend giving some type of local radiation therapy for those situations. Sometimes we give a medicine to protect the bones too. Those are one of the name of the medicine is called Someda, and the other one is called denosumab. So those are the type of medicine that help protect the bones too. So for their breakage in the future, especially when we see these type of bone metastases, not only related to neuroendocrine tumors, but also for other cancer types as well.
So Marge has a follow-up on that question, and Marge says, following up to that, that question, is there a typical path from the small bowel? Mine went from small bowel into the bone and the liver, and is now questionable.
Right. It's not very common to see that. And so that will be an answer to the question. It's not very common to see from the small bowel to the bone. We usually see first from the small bowel to the liver. Right. That's what we have seen, but not necessarily to the bone. So the fact that it went to the bone first is very uncommon. And I don't think that's a rare as well.
Got it. So kind of sticking with bone issues, but a little bit different approach. Jennifer says, can you address the impact of Lutathera on bone marrow, specifically white and red blood cell counts?
Yes. Oh, that's an excellent question. And I always, I have to mention that Lackness is actually working on having a seminar to address that issue, because it's a very common question too, like how much Lutathera can affect the bone marrow and what will be the long-term complications as well in the bone marrow. What we know from the studies that were done as well from the Nether study, so that's the Nether study is what allows to get approval of Lutathera for the GI and then for the pancreas neuroendocrine tumors, is a very small percentage can develop myelodysplastic syndrome. Approximately 1% of these patients may develop myelodysplastic syndrome. Myelodysplastic syndrome can affect every line in the bone marrow that produces cells, like the white blood cells, the red blood cells, the platelets too. It's not very common, but that's something that we see long term. I think that we don't know who patients are at risk to develop that. What we know sometimes is a patient has received chemotherapies that may place in a risk to develop this myelodysplastic syndrome, but I think that's something that we're also trying to understand. And I have to say, Lackness is also trying to bring that webinar as well to kind of help us understand more, because it's a question that a lot of people ask. I agree.
Yeah. Jill says, how common is it for pheos to go into the bone and lung?
So for pheochromocytoma, yes, it's actually more common to go to the bones compared to the other neuroendocrine tumors like the pancreas and the GI. Sometimes on pheochromocytoma, we only see what we call bone dominant disease, meaning that we only see it in the bones, but not necessarily in other organs like the liver, the lung. So we have seen that. And also we have patients that have a paraganglioma that they may have also some lung metastasis as well. I actually have quite a few patients that we're seeing here that we're considering for our study that they have bone metastasis as well as lung metastasis as well. But yes, I have to say is more common to see pheochromocytomas or paragangliomas going to the bones that with the GI and pancreas neuroendocrine tumors going to the bones.
Got it. Thank you. Fred says, what are the main symptoms of a typical lung net versus atypical lung net?
Yes. So typical and atypical is based on the Ki-67. So let me just, I'm sure, and I have to say, Rain say earlier, there are so many videos and so many luncheon with the experts that is taught a lot within these videos. I always learn also from my colleagues as well. Every time is there so much information that you can refer to, but let's just talk about the Ki-67. Ki-67 is a proliferation index. It tells me how the cells are able to divide looking under the microscope. That's what the Ki-67 is. So in terms of typical, because it's typical and atypical is based on the Ki-67. Typical is usually when the Ki-67 is less than 10%. Atypical is when the Ki-67 is a little bit higher. So, and that's kind of like help us differentiate. Atypical, it's the tumors may grow more rapidly compared to the typical low neuroendocrine tumors. That said, I understand that the WHO, which is kind of like the organization that help us divide all these pathologic classification, is trying to help us understand, because sometimes this can be a little bit confusing. I agree.
And is there any hormone production from a lung net?
It can't. Not very common, like we see it with the small bowel neuroendocrine tumors, but the lung neuroendocrine tumors can certainly produce serotonin, can certainly produce another hormone called histamine. Sometimes these patients, whenever they produce serotonin, sometimes may not necessarily have the symptoms of diarrhea. Sometimes they do, but a lot of these patients with lung neuroendocrine tumors that produces hormones, they may experience some shortness of breath, some wheezing too, some rashes. So, but yes, the lung neuroendocrine tumors, they can also produce hormones, rarely produce that. One other hormone that I would like to mention that is very uncommon, but I would like to mention is a hormone called ACTH, and I don't know if you ever heard that, Rain, but ACTH is the one that sends the signal to the adrenal gland to produce cortisol. So if you have a lot of ACTH by these lung neuroendocrine tumors, it's going to send the signal to the adrenal gland to produce a lot of cortisol. And then we have a picture of what we call a Cushing's syndrome, this excess of cortisol, and they can cause a lot of symptoms and complications related to that. That is very uncommon as well, but we have seen it, this with the lung neuroendocrine tumors, as well as with the thymic neuroendocrine tumors. Maybe one of the reasons why we see a lot of those patients here at the NIH is because we have our Cushing expert here, and we see a lot of these patients here. But yes, the reality on the outside of the NIH is very uncommon to see a neuroendocrine tumor producing this ACTH hormone.
Yeah, folks, I had talked earlier about all the different videos, and Dr. Del Rivero just mentioned that too, that we've done over the past 10 years. Well, in 2020, we did an updated treatment-based video series, and I reposted this one recently because we've been talking a lot about lung nets. But if you go to our video section on the Facebook page, and we have them separated into playlists. So Luncheon with the Experts has its own playlist, which there's like 100 and some videos. And there was one from CCF video series in 2020, and there's only 8, but there was one we did on lung neuroendocrine tumors and dip neck. And the patient that we featured, which came from Dr. Ramirez, had the ACTH. ACTH, yes, which is uncommon, but we actually featured her story in this video. So if you want a little more information on that, you can see that there. So just a coincidence. And one more question in that space. Can surveillance, these are from Fred, by the way, can surveillance of a lung net be done with a thoracic MRI instead of a high radiation thoracic CT scan?
So usually what I do in my practice is just follow with a regular CT scan with IV contrast. So we call that dry CT, and that's something that I do. I mean, MRI doesn't necessarily, it's a simple CT scan, is simple, is rapid. I understand about sometimes the concern. Some of the patients say, well, I don't want to do CT scans, I'd rather do MRI. But sometimes I explain the patients, the risk to develop any other type of cancer is a very long time of exposure of this. We're talking about more than 20, 30 years of that, more years to that, and a lot of radiation to that. So if we're doing a CT scans, it could be every 6 months to 12 months. I don't think that there might be a lot of risk, but I do recommend just doing doing a regular CT scans with, without IV contrast, and that gives us enough information.
Okay.
My thoracic surgeon here, because I do have a thoracic surgeon who does a lot of neuroendocrine tumors. So the patients that come to me that require surgery, Dr. Juan, who is the thoracic surgeon I work with, he likes to have very specific CT scans, like very, very short cuts, like, so that way he can see every single part of the lungs too, so that to see if there is any small lesions that may are unable to see with these larger cuts that we see on the CT scan. But yes, CT scan is better than an MRI in my experience, and I prefer CT scan.
Got it. Thank you for that. And thanks for your question, Fred. From Jessica, is it possible to have a clear dotatate scan and still have an active neuroendocrine tumor somewhere, especially if there are multiple symptoms, flushing, fatigue, anxiety, blood pressure elevated, high blood sugar, mood changes? And for some context, the original cancer is an atypical carcinoid of the lung.
Yes. Thank you for that question. And I'm sorry. I feel like I have seen some of these patients as well in my practice, and I can understand how frustrated this can be. The fact that, I still have symptoms, but I don't see any neuroendocrine tumors on the scans. And I I understand, but sometimes the way we make recommendations is sometimes, based on symptoms, but also based on what we see on the scans too. If we don't see anything on the CT scan or the dotatate scan, so the dotatate scan is a good scan that help us also to look if there is any neuroendocrine tumors in the body, because as I explained earlier, and I'm sure many of the net experts here, is that it has the receptors, these neuroendocrine tumors has the receptors, and because of that, we're able to do the dotatate scan. Sometimes when a patient has surgery symptoms, I recommend a dotatate scan just to give me information whether there is something that we're unable to see. Sometimes the dotatate scan can't give more information than the CT scan or the MRI, because sometimes they're very small to see it on the CT scan, but if they have if they have the receptor, sometimes we're able to see it better on the dotatate scan. Sometimes I like to do a dotatate scan. The issue is whenever we don't have whenever the dotatate scan is clean, what do we do? So I understand how frustrated it can be. I try to continue, having a diary of the symptoms as well. Sometimes in those patients, a trial of what we call the somatostatin agonists like lanreotide or octreotide can help with some of the symptoms. And there is another scan that is called the FDOPA scan. It's a research scan. And there is some data that maybe FDOPA can help with that. It's not available and everywhere. It's only available, I think, in 2 institutions within the United States, because it's considered a research scan. I have to tell you that we did hear that dotatate scan versus FDOPA. We kind of compare whether to determine whether FDOPA could be better than dotatate scan, but we didn't see any difference. So I still feel that the dotatate scan is a very good scan, but I understand. I'm sorry that I cannot give you an answer to the symptoms of what you're going through, but yeah, I can understand that this could be sometimes frustrated, but just continue having a diary of the symptoms and don't ignore it. And we can always, maybe something very small that we're unable to see right now, but maybe able to see it later. But yes, continue having a diary of the symptoms, and maybe there may be something else that, is causing the symptoms too. Like I say earlier, I think there was a similar question earlier as well. So it's important to know what the symptoms are to then understand whether we need to do other workup. Some of the flushing can be caused by many other hormonal imbalances as well. Even a disease called mastocytosis, they can do that. Mastocytosis can also cause diarrhea. So I think it's important to understand a lot of the symptoms, because sometimes that can help us understand whether we need to do further workup that may not be necessarily a neuroendocrine tumor. I don't know if that's the question.
Yeah, thanks, Jessica. Hopefully that helps a little bit. But if you have any other questions, we still have some time, so send those in. Question from our friend AG. Please repeat your recommendation for how we mention our gallium and copper scans, receptor scans.
Mm-hmm. So maybe I can just discuss what is the difference between a gallium dotatate scan or a copper dotatate scan. So the gallium dotatate scan was the very first one. Whenever we have the approval of the dotatate scan, was the gallium dotatate scan. And then the copper came after the gallium DOTA scan. In terms of detecting tumors, is the same. However, we don't have a study that really have a comparison whether one is better than the other, but based on the recommendations from the nuclear medicine physicians, we feel like the sensitivity or the ability to detect tumors is the same between either copper or gallium. The difference is the half-life, meaning how long they're able to be used to do the scan. Gallium 68 gallium DOTA scan is 1 hour, where the 64 copper DOTA scan is about 12 hours. So sometimes, you know, maybe some institutions may have availability of the copper rather than the gallium, just because if something happened, like if I into traffic, if my appointment is at 9 a.m. to have the DOTA scans and I'm stuck in traffic and I'm an hour later, I may not be able to have the 68 gallium DOTA scan, where the copper, the half-life is much longer. So I think that's kind of like the difference between the two of them. But in terms of detecting the tumors, is the same. We feel like it's the same. There is no one better than the other.
Got it. Thank you. From Maurice, our friend from Ireland, I've received 7 rounds of PRRT in Sweden, and this was 3 years ago, and I've been stable since then. And I'm just wondering, is it possible to get repeat rounds of PRRT? My net primary was in the small intestine. Thanks.
Okay. That's a great question. So, and that's one of the questions that also we would like to answer, is what is the doses that are approved for doses of PRRT with Lutathera. So it's given every 8 weeks for a total of 4 doses. What we're trying to understand, and I have to mention Dr. Chauhan is doing the study, is the retreatment, whether we can give more treatments, what is the benefit and how many, because we don't know, even if the patient has received 4 cycles, we don't know how many cycles after that we can give. But what we know is that, yes, there is a benefit. If we see a benefit of the first 4 cycles given Lutathera, we do recommend giving more cycles of Lutathera, because there is a benefit of the treatment. The question is, like, we don't know how many cycles after that. I do feel like the more cycles you get, sometimes it can affect your bone marrow. So we discussed earlier about the bone marrow and how it can affect the cells, even though the risk is low and the risk is higher for patients that have received chemotherapy. There is still a little bit of a risk, and the more cycles you get, it's possible that it can affect more your bone marrow. But that's a good question. We don't know how many cycles. Seems like you got 7 cycles, is that right? So 3 cycles after the initial 4. That said, here at the NIH, we also have a study of retreatment on pheopara, meaning that if the patient has received 4 cycles and there is a benefit, we recommend 4 cycles after that. So, and we kind of help us understand as well, you know, kind of like the many cycles that the patient can get and is able to tolerate. I think that's a study that can help us also understand about the benefit of how many cycles we can get. But if there is a benefit of Lutathera, yes, I think the question is the treatment, and we're still trying to answer those questions. That said, I'm sure you have heard this from the net experts here, and with Rain, is that we have now the alpha PRRT, and that's still on clinical trials. I know it's more available in Europe compared to the United States. The United States, we have it in available in clinical trials, but PRRT is, maybe, we don't know, maybe more effective, maybe safer than Lutathera. We don't know. That's a question that we wanted to answer as well and understand about the alpha PRRT. But if there is a benefit of Lutathera, we can get a treatment. If there is a benefit of Lutathera, we can also recommend alpha PRRT. So there are options in those situations. I don't know if that answered the question.
Got it. Well, let us know if you do have a follow-up question, and we'll try to get that. We got about 5 minutes left, so we are going to keep trying to get as many questions as we can. From Dwayne, do medications such as Ozempic have any effect on pancreatic polypeptide levels?
That's a very good question. Ozempic is an medication that is used for diabetes, and is also, I believe, it's approved also for weight loss too. Yes, that's a good question. I have not seen that, and I'm sorry that I can answer that question. I definitely, if you send me an email, I can definitely ask to my colleagues. I don't necessarily prescribe, even though as an endocrinologist, I don't necessarily treat diabetes. But yes, I mean, that's a good question as well, whether the Ozempic can increase or falsely elevate the pancreatic polypeptide. But yes, I'm not aware of, but
Okay.
definitely I can ask to my experts here. And if you want me to follow with that question, I'll be happy to answer that.
Thank you. From Jill, how often is it safe to get a dotatate scan for a pheo per year?
Mm. So, and this is so I would tell you what I do, and I think that's what most of the NET experts also do, is that we follow as patients either with CT scan or an MRI. If we see something up different on the CT scan or something abnormal on the CT scans, then I could consider doing a dotatate scan. I don't do dotatate scans either every 6 months or once a year. I usually do it whenever it is necessary. And the reason why is because dotatate scan and pheopara can help me for 2 reasons. Number one, it can help me also delineate how many tumors we see that are correlated with the CT scan or the MRI, but it also helped me determine whether Lutathera could be an option for those patients as well. So again, I don't necessarily do dotatate scans every year. I do it, whenever I see something abnormal on the CT or an MRI. That's usually standard practice. I can tell you here in our institution, Dr. Carl Patzak, I believe he was here and a couple of occasions as well. And please feel free also, to go back and like Rain said and listen to
For sure.
as talk. But he on his study, because he also have a natural history study for pheopara, he does multiple scans every year. Does what we call functional imaging scan. He does this every year because he wanted to understand which one is better, whether we can do it every year or shorter or longer. So that's one of the questions that he's tried to answer by having this study.
Got it. Thank you. Quick follow-up from Jessica, who asked the question earlier about the clear dotatate scan, but all the symptoms that she was experiencing. She says, what was the medication that you recommended that to help with some of those symptoms? Do you recall?
Yes, there's somatostatin agonist, lanreotide or octreotide. Not something that I recommend. I think that is important to discuss with your primary care physician or whoever is your treating physician to understand where the symptoms come from, whether further evaluation or workup needs to be done. But I have also seen that some patients may feel some benefit by using these injections once a month, which is usually what we recommend for patients that have neuroendocrine tumors or metastatic neuroendocrine tumors, because the function of these injections is it has 2 functions. Number one, it can help with the excess symptoms related to the hormone excess. And number 2, it can also help slow down the growth of the tumors related to the neuroendocrine tumors.
Got it. From Angel, is it normal to have symptoms like flushing after a hemicolectomy? Doctor says no signs of NETs after surgery.
Oh, so flushing is one of those symptoms. Like there's so many things that can cause flushing, not necessarily neuroendocrine tumors.
Right.
I think it's important to understand, as well where the symptoms occur, whether it's associated with anything you eat or anything you did. I think flushing is one of those not necessarily specific symptoms that, and so many things can cause flushing. So I think it's important to discuss it with your treating physician about that. And again, whether any further workup needs to be done.
Got it. Follow up to the PRT bone marrow question. Is there a higher risk of bone marrow issues after everolimus as there is after chemotherapy?
So everolimus chemotherapy certainly, yes, can affect the bone marrow, but especially because one of the agents that we use, especially for the pancreas neuroendocrine tumors, is the combination of capecitabine and temozolomide. Sometimes that can also affect the bone marrow, and then maybe that's one of the reasons why we don't like to give it long term. So some of the question is like, how long do we give the treatment to? But everolimus doesn't necessarily cause any effect on the bone marrow as the chemotherapy. That said, it does have other symptoms too that you need to keep in mind.
What This is a question from Jill. What's an email, or can someone reach you for a follow-up question? Are you open to?
Yeah, absolutely. Yes, I'm here. Any questions that you may have, anything I can do for you to help, absolutely. Please.
Great. Hey, Jill, we'll put that in a reply to your comment. So stick around. Jessica says, thank you so much. I've gotten more questions answered here than I have in a long time. Jessica, that is our job. That is why we're here. We love to hear that. That's exactly what we're trying to accomplish. And Heather says, Dr. Del Rivero is a gift to the NET community. Thank you for all you do for so many. I have to agree with that. You're a gift to the community. You're a gift to this show. We appreciate you being here so much. Thanks for sharing some time and some knowledge with us and with everyone in attendance today. Appreciate you being here.
Thank you. Thanks so much.
Absolutely. And thanks to you all at home as well. Again, we hope that this program helped answer some of your questions. And I'll reiterate one more time, feel free to reach out to us on here on the Facebook page. You can send us a message or at carcinoid.org. And remember that thing I said earlier, send me a message if you can think of any great patient stories of hope that you would like to see made a film out of. We do about 10-minute short documentaries. Let us know. Thanks again to our presenting sponsor, Ipsen Biopharmaceuticals. Without their support, we couldn't do the show. And finally, my name is Rain Bennett. I have been your host. Thank you for watching. And please join us next time on Luncheon with the Experts. Stay healthy, stay safe, everyone. Bye-bye.
Thank you so much. Thank you.